Welcome to Boston Children's Answers Parentcast. I'm your host, Jennifer Arnold. As a doctor and a mom, I'm passionate about helping kids stay happy and healthy. So join me as I chat with other Boston children's experts to find answers for you and your family. Hey everyone, and thanks for joining us. Today we're talking about irritable bowel syndrome, or IBS, something that I think a lot more kids than we realize might be dealing with. It's always hard as a parent to differentiate between a typical bellyache and something more serious that you need to have evaluated. So here, as always, let's start off with a question from our parent.
Hi, I'm Amy. I'm wondering if I should be worried about my 12-year-old daughter. She's been complaining about bellyaches for months now. Do you have any insight?
Amy, that is such a good question, and it's a very common problem in pediatrics. Today we have an expert, Dr. Beate Beinvogl, who is a pediatric gastroenterologist here at Boston Children's Hospital, to help us work through this. Thank you so much for being here today.
Thank you for having me.
I like to start off every podcast getting to know our expert, and I'm curious how you got into the field of pediatric gastroenterology.
Very early on in my training as a pediatrician, actually, I was in a program that was very much focused on pediatric gastroenterology. And I was always intrigued by kids coming in for abdominal pain with the testing not showing anything obvious that would explain their pain. And so they would be left thinking, what's going on? Like, there's nothing wrong with me, but there is because I'm having pain. And so I have, very early on had that goal to build my career on helping these patients to understand why they have pain and what we can do about the pain, and also doing some research in that area to better understand.
Abdominal pain in kids is not that rare.
Abdominal pain is very common. The causes of abdominal pain, of course, are pretty broad. And so I like to think of it like a computer or a phone, for example, like the hardware and the software that makes up our body. And so when you think about the hardware of the GI tract, right, we have the esophagus, the tube we swallow through, the stomach, where food gets processed in the intestine. And so things can be wrong on what we call the mucosa, the lining, for example, of the GI tract. And usually those are things that we can see pretty well, either with labs, blood work, endoscopies, things like that. So I consider that a hardware problem. It would be like opening up a computer and you see that like one of the chips is missing, or something is broken, or the screen is cracked.
Yeah.
And then there's sort of the other part of software in our body is, in the GI tract, is how things are felt, right? The sensors, and then how things move, so the motility. And so you can have issues with that software, which then results in symptoms. The software glitch, which is very common, but I think much less understood. The caveat is that there's not a specific test for it, which sometimes makes it harder to sort of understand it as a diagnosis.
I think that's such a really helpful way to think about it, though, right? Because I imagine for so many kids, they have a stomach issue or stomach pain, they go see the doctor, and if they do get that full workup and then nothing has seen, we have to figure out how we can still support kids that have functional abdominal pain.
Functional abdominal pain would be sort of just having pain, and then irritable bowel syndrome, which is, of course, what we're talking about today, is sort of a slightly different presentation. These kind of software glitches is what we call disorders of gut-brain interaction. And that's where irritable bowel syndrome is one of those disorders of gut-brain interaction, or DGBI as we abbreviate it.
So thinking about, irritable bowel syndrome, who's at risk for it?
We generally think of it as there being a genetic predisposition. So a family member, close relative may have irritable bowel syndrome, or may have another chronic pain condition like migraines, fibromyalgia, other things like that. Or even some mental health conditions have been shown to be sort of a predisposing factor, like anxiety, depression, that you may be more likely to develop irritable bowel syndrome later on. But of course, not everybody that has a family history will go on to develop irritable bowel syndrome. So a child is born with these predisposing factors, and then things happen, right, throughout life early on. Which may not cause any symptoms yet, but anything that affects how the nervous system develops and how the pain pathways develop, anything that plays a role, or that plays into how those pain pathways are stimulated, it can affect how the pain system works and processing works, which is a big part of what happens. For example, early on, very recurrent infections, trauma, whether it's physical or psychologic trauma. We know that babies that have been in the neonatal ICU that have had a lot of interventions done, breathing tubes and lots of heel sticks and things like that, they have been exposed to pain, and so their pain processing is different. And so these things all, other comorbidities, anxiety and depression, and modeling in the home if there's somebody else with, chronic pain, for example, that all sort of like plays into the risk of developing something like irritable bowel syndrome.
Wow.
And then we think of it as sort of something happens in about 60% of patients when they have a condition like IBS. They can tell us this is what happened and then the symptoms started. And most commonly, those are infections. I like to compare it to long COVID. You have an infection, the infection is gone, but you continue to have symptoms. And so similar, that can happen in the GI tract with IBS. But we've also actually found patients reporting things like non-gastrointestinal infections, major surgeries, major injuries. So again, any hit to the pain system, if you will, even being diagnosed with a medical diagnosis like celiac disease or inflammatory bowel disease, you treat that condition and they still have symptoms. So you have this predisposition, and then there's a trigger that sort of like just brings the volcano to erupt or the cup to overflow, and then you have the symptoms of irritable bowel syndrome, for example.
There's clearly got to be an impact to the pain system. I think your explanation helps us to understand just how important that connection is between the brain and our GI tract and how things can go awry. But you may not see anything because you were saying it's a software issue. So for kids who have IBS, they, when you do all the tests and all the workup, you don't see anything wrong.
Yeah.
And that's so hard.
And I think that's what makes it so difficult for patients, but even other providers, because it gives this flavor of, well, if we can't test for it, then it's not real.
Yeah.
And I think that is very wrong.
Yes.
Because obviously, if my child is complaining of pain, they're having pain, right?
Yeah.
And I think a lot of patients and families feel dismissed because they're being told, well, all the tests come back negative, and then either it's all psychological or it's all in your head, or, I hear the wildest things, and that's really not the case. These are real conditions. And, the truth of it is that we're understanding more and more on a level that's just not yet ripe for clinical day-to-day practice, that there are abnormalities that we can see within the GI tract, but they're just not measurable, on a routine level.
So more research is like we need to understand this whole collection of disease, sort of conditions, right?
Yeah. The basic underlying mechanisms, we understand, but sort of what plays into them, absolutely, we need to understand more. And I think the two key factors are that there's this hypersensitivity within the GI tract. We feel things that normally our brain can sort of filter it out, but we're feeling it because there is an increased sort of sensory thing happening in the GI tract. And then the other part is, and we call that visceral hypersensitivity. And then there's another part, which is the brain, which is where all the signals arrive. And that in these disorders is also like hyper aware. It has a harder time filtering out signals that come up. And so that's what we call central sensitization or hypervigilance also. And those two aspects are both extremely important.
So can you just define for our audience, what is IBS and how does it fit in with the greater collection of these disorders?
Yes. IBS, or irritable bowel syndrome, is a condition where patients experience abdominal pain and have abnormal bowel movements that are either more towards constipation, more towards diarrhea, flip-flopping in between, or sort of all over the place. And that depending on sort of what the predominant issue is in conjunction with the pain, whether it's constipation or diarrhea, we call it irritable bowel syndrome with diarrhea or irritable bowel syndrome with constipation. The diagnosis is actually made based on meeting clinical criteria.
Okay.
And if you have symptoms more than a certain number of times over the course of 2 months or longer, then you meet criteria for irritable bowel syndrome. And I think the important thing to understand is that it's not a diagnosis of exclusion.
We say that a lot in medicine, right?
We say that a lot in medicine, and Usually anybody that comes in with abdominal pain, they need to be tested for certain things. But we don't need to go, if we're pretty certain somebody has irritable bowel syndrome and they don't have any, sort of alarm signs in what they're telling us in their family history or other symptoms, then we can pretty comfortably make that diagnosis very quickly. And we actually don't need a lot of tests to rule out other things.
They don't need to go through this exhaustive battery of tests. That's probably really, really assuring for parents. This is important stuff that we all deal with.
Yeah, it's interesting with these, anything GI related, if we're experiencing that, like nobody really wants to talk about it, right? It creates an unbelievable burden.
Yes.
We don't want to go to school if we have to rush to the bathroom, every 10 minutes or every hour, or even once during the school day if it's a, sort of an urgency. And so you can see that very quickly, this sort of draws bigger circles of how it affects people's lives. Yes. And, if they're triggered by certain foods and not able to go out or not wanting to spend time with friends, the quality of life or reduction in quality of life associated with IBS can be significant.
Yeah, because it affects every part of their daily life. And no kid should have to deal with that burden. And particularly in an age like, when kids are just wanting to fit in, the pressure is really just really hard on kids. So if IBS is a software issue, does that mean that it doesn't actually lead to damage to the stomach and or intestines?
There's no, visible damage. And so we think of it as hurtful pain, but not harmful pain.
Okay.
Right? So it's hurtful because the symptoms are as if you were having a hardware problem, right? But it doesn't actually cause damage to the GI tract. However, it is very damaging to someone's life in all spheres, emotional, physical, school functioning, just sleep, you name it.
So just like any health condition, it affects everything, right? That it impacts a kid's daily life.
Yeah.
Oh.
And, sometimes very little and sometimes significantly. And that's sort of also where we, different sort of needs for patients in terms of treatment and support will come into play.
So knowing that this can have a big impact on kids, how common is it in children?
Studies have shown in middle and high school, 8 to 15% respectively will have had symptoms of irritable bowel syndrome. Now, that doesn't mean they all go see a doctor, but that they've experienced symptoms that meet those diagnostic criteria. So very common.
Wow. Are there any particular populations of kids that are more at risk?
Girls are more often affected than boys. That is something that's still being actively studied, but hormones definitely seem to play a role. Estrogen, progesterone, we know can have an effect on GI motility, right? Constipation, diarrhea. Constipation is more common in females as well. And we also know that it's more teenagers in and after puberty. We rarely see this actually before puberty.
Wow. Well, the signs and symptoms to be aware of would be really important so that we're not missing the diagnosis and the impact that it might have on kids, especially given the high incidence of it. What are those signs and symptoms?
Abdominal pain and abnormal bowel movements, being constipated or having diarrhea, and oftentimes related. That, the abdominal pain, cramping, for example, bloating, it gets better or worse with defecation, with stooling. We know this concept of visceral hypersensitivity. So the sensors in the GI tract are more likely to sort of feel things that they, quote unquote, shouldn't feel. When there's stool in the colon, a lot of people don't feel it, or if there's a little bit more, they feel like they have to go to the bathroom. But it's not like there's a lot of pain, right?
Yeah.
A patient with IBS might feel like they're constipated, though really they're not super duper constipated, if you will, right?
I see.
And so that even when you treat constipation, that oftentimes they still have pain because it's not the constipation, it's basically their stool and the hypersensitivity, right? And that's a very key point.
Yeah.
And so we see a lot of kids that go through lots of clean outs and they just don't get better. And so, right, if the constipation got better with a clean out, it wouldn't be irritable bowel syndrome, they would have constipation.
I see.
And I think that's a very important difference to understand, why also patients get very frustrated. Like, yes, I have IBS with constipation, but treat the constipation, it should go away. Well, that's not how it works because you still have that hypersensitivity. And the same thing is you have a little bit of bloating and you may not even see it. A little bit of stretching creates a lot of noise, a lot of pain. And that I think is just a very important aspect of IBS that's really important to understand.
How can you be aware that, maybe I need to have my child checked out?
Sometimes it sneaks up on you, right? Like
Yeah.
You think you don't want to make a big deal of it, and you say, oh, well, there's a little bit of pain. It's okay. You're probably just constipated. And it gets better maybe a little bit after constipation. And then it's like again and again.
So that's that persistence.
It's the persistence for sure. And then, of course, if there are any other concerning symptoms, you should see a doctor for it, because any abdominal pain, even milder pain that persists, is worth seeing your doctor because we can help.
So along those lines, are there any red flags that parents should be looking out for too?
When patients come to us with abdominal pain, there are always, there's a differential, other things that we think about, and we ask questions, and there's certain things that raise our concern that there could be a hardware problem, and then we would pursue that. We always want to rule out things like celiac disease, for example, or, is there any, are there low blood counts that could suggest there's some sort of chronic disease going on? So some basic lab work. And then there are things that would raise our concern if there's unintentional weight loss, for example, if there's blood in the stool, if there's, associated vomiting, if the pain is very severe, very localized, things like that. I don't need to go into all of them.
Yeah.
If there's a strong family history of certain gastrointestinal diseases like inflammatory bowel disease, that sort of would make us pursue some more testing. Not a lot more, but some more testing.
Yeah. So just like everything, right? We have symptoms, and you have to go through the differential, but sometimes that history is so helpful in really targeting your evaluation.
Absolutely.
So I'm wondering about the evaluation. Where can individuals go for evaluation? Can they go to their pediatrician? Does it need to? Do they need to see a gastroenterologist? How do folks navigate that?
Yeah. Not everybody needs to come see us, or not right away. And, I just want to emphasize too, there's a huge spectrum of how patients present. Sometimes very mild, very intermittent symptoms. And some kids, they can't get off the toilet in the morning and get to school, or stay in school for that matter, because the pain is so severe and the symptoms are so severe. And so the pediatrician is the first place to start.
Yeah.
Definitely the pediatrician, and not the internet.
Yes.
But and then they will, most likely do some very basic evaluations, and hopefully present also some interventions, and then and if either the symptoms remain or worsen, or the interventions are not quite helping the patient get better, that's oftentimes when they appropriately get referred to a pediatric gastroenterologist, if available. It's not that easily available for everyone. And within pediatric gastroenterology, this is a very common thing that all of us see, but then even within pediatric gastroenterology, there are some, like myself, for example, that sort of have a special focus in seeing patients with these kinds of disorders of gut-brain interaction, including IBS. And so we then often see patients that are very disabled by their symptoms and have sort of more support available to help.
It's a tiered response, which makes sense,
Exactly.
because there can be so much variability, it sounds like. So you mentioned, symptoms have to have sort of persistence for a certain amount of time. How much time is that?
To make the diagnosis of IBS, we say that symptoms should be there for a longer period of time, like 2 months. But the bottom line is that, you should get help when you're worried enough.
Okay.
And so if either the pain, is happening so frequently that it's affecting the child's life. If it's happening very infrequently, it's fine to wait a little bit longer, sometimes even months. If they're living their life, if they're eating, they're not losing weight, and they're otherwise doing okay. So it depends a little bit on the severity of the symptoms for each patient, and then also just how much their day-to-day life is affected by them. I think the bottom line is that if there's concern, the better, the sooner the better, because it's good to know what you're dealing with.
Don't hesitate to seek help from your pediatrician as a starting place.
Yeah.
So along those lines, when kids are diagnosed, is it difficult for kids and parents to accept this diagnosis?
For some, it's very easy, and for some, it's very difficult. And we're so used to our medical, fancy diagnostics that it's hard not to have a diagnostic test for IBS. I think that there is often a lot of anxiety, sometimes on the patient side, but often also on the parent side that we're missing something. And you know, it's understandable.
I can see that, yeah.
Right? I mean, my child is having significant issues,
Yep.
you know, maybe resulting in a significant disability in day-to-day life. And, you know, there's got to be a test for this. It's so severe.
Yeah.
And the truth of it is there is no diagnostic test. And yes, this is how severe symptoms can get. You know, there is this temptation out of anxiety to keep running more tests to rule out other things. But we have actually found that unless it's really indicated, it tends to lead to more anxiety because it keeps coming back. Oh, there's nothing wrong. There's nothing wrong. There's nothing wrong.
It feeds the
it feeds the opposite of what we're trying to achieve. It's my job as a doctor, if I'm worried, to do more tests to do it, right? But if I feel confident, then I make the diagnosis. I do what I need to do in terms of testing. And that doesn't mean we will never, ever do another test. If, that's why we see patients for follow-up.
Yeah.
It just means let's move on and treat this.
Yeah.
Let's
use that sort of the tools in our toolbox and the knowledge of, what IBS is to help guide so that you can move on for treatment and help your child. That's got to be hard for families, though. I mean, this is...
Sometimes it is,
yeah, a complex disease. Now, can IBS ever be mistaken for other conditions?
Yeah, I mean, abdominal pain, diarrhea, constipation, I mean, those are very common complaints.
Yeah.
And also, of course, symptoms of other diseases.
Yeah.
So again, celiac disease, inflammatory bowel disease, certain, food intolerances, like lactose intolerance, for example. So those are all things that we elicit during history and with some basic testing. But yes, definitely, there are not that many different GI symptoms that you can have, so to say.
Getting the diagnosis is so important, it sounds like, because that's going to help families really, own what it is, understand it, and then treat it. So what are the treatment options available for kids who have IBS?
There are multiple, and we think of it as truly multidisciplinary and multimodal. Depending on how much patients are affected by it, that may require more interventions and less. But maybe before I get into those specifics, I think one other thing that is really important to understand in typical treatments, there's a problem, we diagnose it, we fix it, like strep throat, you test it, you give antibiotics and it's gone. Appendicitis, you take out the appendix, gone. This is not how IBS works. IBS follows biopsychosocial models. So you're born with this genetic predisposition. You have certain biological factors, maybe early pain triggers, like we had
talked about.
You may have other issues. You may be struggling with some anxiety. You may have stressors. You may have, some things for concern around depression. These are all things that matter because all of these things affect how you feel pain. Pain is a very individual sensation. And so so that's why we take a history. We really want to get to know patients. Every patient may have different triggers, right?
Okay.
So we talked about the abnormalities of visceral hypersensitivity, central sensitization. That is sort of the underlying problem. But that gets triggered by in different people. So some patients, anxiety may be a trigger. That doesn't mean it's all related to anxiety. For some patients, certain foods might be a trigger. For some patients, getting up early for school as opposed to being able to sleep in might trigger some of these symptoms. Wow. Sometimes like hormonal changes, in the menstrual period can trigger symptoms. And so so that's why it's important to sort of take all these things into account and then tailor a treatment approach. And that's not a cookie cutter type of, treatment. Sometimes it's very obvious. If there's a child that, every time they go to school on Monday, they get a lot of abdominal pain and diarrhea, and they may or may not feel actually how anxious they are, that can be a trigger. So we have to work with that anxiety.
Yeah.
Yeah. And I like to talk about it specifically triggering as opposed to causing, actually, because when we think, we talk about causing, then we're sort of saying it's all anxiety.
Oh, I see.
It's a nuanced difference, but I think it's important because I get so many patients that say, oh, my doctor said it's all from anxiety, but I'm not even anxious.
Yeah.
So that's why in some patients, anxiety is a trigger,
but not
in everyone.
So it's important to be careful not to say it's caused by something, because everyone's got their own triggers. That's really important to know that it's not causing it. It's something that someone's predisposed to, like you said.
Right. So, it would be like, for example, if you have lactose intolerance and you have, regular milk and you have symptoms that can actually mimic IBS. If that's the only problem, you take away lactose and you should be fine. Yeah. Right. But in the case of IBS, patients might be triggered by lactose. It might bring on their symptoms, but it doesn't mean that's the only reason, the only time they feel symptoms. If that makes sense. Yep. Like there might be other foods too that trigger them. So you get the idea.
They've got an underlying condition that then can be triggered by various things.
Exactly. Yep. And so the treatment then in sort of two big categories is we literally treat symptoms, and the other is that we identify potential triggers or mechanisms that play a role. Remember, we talked about the fact that there is constipation, so there may be a slower transit, and so we want to treat constipation, but that's not going to solve the whole problem, and yet it's still important because even a little bit of stool can cause a lot of symptoms. Yep. So that's the idea that treating the symptoms, and to do that we use different medications that are, we use laxatives, again, within reason to treat constipation. We use things to slow down the bowel if there's a lot of diarrhea. We use anti-cramping medicines. We use medicines to calm down the nerves, to treat that, visceral hypersensitivity. And then we use medications and other interventions to treat trigger. If, for example, there's a disruption of the bacteria in the gut, right? The microbiome, like we know that can play a role. We might use a course of antibiotics. And so, we use diet to see, are there specific foods that may trigger some patients? If there aren't, then we don't worry about the diet. We let them eat whatever they want. And if we do identify some foods that are triggers, and there are certain that are more common than others, then we may help patients to find out exactly what are their main triggers and then find alternatives. Wow. And so, the sort of, you may have heard the acronym high FODMAP foods. It's an acronym that stands for certain types poorly digestible carbohydrates, basically. Common ones being like garlic and onion and lactose, certain fruits. It's not very intuitive, but it's, there's sort of a way that you can explore. And sometimes we try elimination diets like that, for example. And then there's the big, of course, lifestyle interventions, and it's extremely important, and it always sounds so boring, but sleep, exercise, like relaxation techniques that just overall, one, make patients feel better, but also aim at that sort of arousal state of the nervous system with the abnormal motility and the increased pain sensation that creates this aroused state, that we sort of calm that down. And then very importantly, psychological interventions. Pain signals arrive in the brain. That's where we perceive them. So anything that affects the brain, anxiety, depression, stress, poor sleep, can affect how we feel pain. And so it's important to address that, again, as a potential trigger. But it also gives patients the possibility to actually help talk back, not in an argumentative type of way, but in a constructive type of way. To send signals. And, like I like to use the analogy of like learning to turn down the dimmer, right? If this is like super bright light, you can learn how to turn down the dimmer so your brain gets a little bit of a break. So there are psychological techniques that can be helpful, cognitive behavioral therapy strategies. A lot of patients struggle with anticipatory anxiety. What happens if I have diarrhea at school, if I have pain at school and I can't concentrate during the test? And it turns into this monster in the head, and it actually creates so much stress that it worsens the symptoms and they're caught in this vicious cycle. So it's triggering in and of itself, right? Exactly. And so that's when the psychological techniques play an important role in trying to break out of that cycle. And then actually gut-directed hypnosis, as crazy as that sometimes sounds, is extremely effective, where you change the way that your body, transmits signals. Yeah. And then there's other things, complementary medicine like acupuncture that sometimes helps patients
with pain. Right? It decreases pain sensation and thresholds, and because it's used for all kinds of pain conditions.
Exactly.
Yeah.
And then there's a newer device called the IB-Stim, which is an auricular nerve stimulator. It looks kind of like a hearing aid. It has these little tiny little needles that stimulate peripheral nerve centers of the vagus nerve, and a very important nerve of the autonomic nervous system that controls and regulates a lot of internal function. For IBS, that's actually been shown very helpful.
There are so many treatment options for patients, and if I could just sort of think about this, summarizing, it's like treating the triggers, it's decreasing the level of almost like irritability of the gut-brain interaction so that maybe things aren't so susceptible. And then it sounds like there are even treatments that address the physiology of what's going on when these pain cycles happen, so to speak. I think about it similar like a headache, right? Again, there's nothing that you see or can test for, but there are triggers for people with headaches, and they're all unique. And we need to understand, what are the individual triggers? And not everyone gets headaches, but those people that have the underlying physiologic condition to have headaches, and there's a physiologic process that's causing the headaches, which can be different depending on the type of headache. I mean, it just seems like there's so many nuanced relationships, similarities there in terms of how we think about IBS.
And I think that's a very good comparison, and I think a much more widely known and accepted diagnosis based on clinical criteria as opposed to testing. So I think that's very helpful.
But we're behind on the gut side. We need to normalize it so that we can really talk about it and treat it better. Okay, so you mentioned all of these broad treatment options available. How do we treat things here at Boston Children's?
We have the Motility and Functional Gastrointestinal Disorders Center, and as part of that is the Functional Abdominal Pain Program. That's what I'm part of. We see patients that require a significant amount of support to get them to just live their daily life with a good quality of life. And so we have a multidisciplinary team that every patient is seen by that consists of a pediatric gastroenterologist, a psychologist, a nurse practitioner, a pain physician, there's a dietitian, there's a social worker. We are there to identify and treat triggers. We're there to treat the symptom of pain. We're there to help with school reintegration, and we're there for psychological strategies, coping strategies to change symptoms and treat symptoms, like what we talked about, sort of all in one place, which is very helpful.
Wow, that's great. You're probably really targeting your treatment plan, as we talked about earlier, based on that individual child's needs, and especially with those that are just so severe, that's probably really critical to helping them to get back to daily life.
Yes, exactly.
Because there's such unique triggers for every patient, getting that expertise of all these different specialties might really help a kid for success.
The treatment has to be tailored to each patient.
Yeah.
And it's often not sort of a simple, quick fix. It's a process. And I'm not saying that to be discouraging, but more to, ask patients to have some patience with themselves and with the situation. And also that it's sometimes up and down. If stress is a trigger, there might be times when it gets worse, and that doesn't mean it's going to just get worse and worse. Things will also get better again. Yeah. And so that, the fact that it's a path, and that the big picture is we want to rehabilitate the nervous system in a way, right? That hyperreactive signaling that's happening between the gut and the brain, we think of it as rehab. And similar to when you rehab, a broken bone, after whatever time it takes that it has to be in a cast, for example, right? We need to move it even if it hurts a little bit. Yeah. Because otherwise it's just going to get worse and worse. Yeah. And so we encourage them to continue to function. And I think that's where, the parent sort of coaching and cheerleading is really important, that we, in contrast to what we normally do when patients have, or our kids have pain, we're like, oh, go rest, stay in bed. In this case, it's actually, we want to do the opposite. Yeah. We want to encourage functioning. And it's not, suck it up and go. No, it's we acknowledge that you have pain.
Yep.
And at the same time, we know it's really important to continue doing these things, because when kids start withdrawing from life as a result, right, we want to help them to cope with it in a way that they don't have to do that, but not avoid life. Yeah. Because once we get into that cycle, it goes downhill quickly in the sense of becoming more and more isolated. It gets harder to get back to school, back to friends, back to physical activities.
Which is the ultimate goal, right, for our kids.
It is.
Yeah.
And we actually know that the functioning comes before the symptoms improve. If we wait for the symptoms to fully resolve before we get back to doing what we enjoy doing, it's going to be much more difficult.
That's the goal, right? Is to help our kids to be healthy and happy and to get back into the things that they love to do. Is there anything else from a comorbidity perspective that parents might need to know about with IBS?
One thing that's notable is that patients often have software glitches in other places of the body. And unfortunately, because it's one operating system, one sort of puts you at risk for another. So we see, other things that affect either the autonomic nervous system or pain. So joint pain, headaches, fibromyalgia, dizziness. And we also see anxiety and depression disproportionately higher in patients that have IBS compared to those that don't. It's not that anxiety or depression or mood dysregulation causes IBS.
Yep. No.
In fact, we often see patients that have had no issues with anxiety or depression before they have the symptoms of IBS, and then they develop it as a result of the symptoms because they get anxious about having symptoms in places where it may be difficult to deal with them, or because they have lost their joy of doing things because they're so disabled by the symptoms that they actually start having, issues with their mood. I think that nuance is very important to understand.
To tease out and for people to know particularly from an acceptance and an awareness perspective and to be able to sort of like support kids that are going through this. It's all intertwined and connected.
Anything that will improve the functioning of the nervous system and decrease the pain or the dysregulation will help in other areas too. And so that's also why sometimes if we treat the GI issues, we see an improvement in other places too. So there is some connection there. And, I should finish on a positive note that patients generally do very well. When they learn their triggers and they understand these diagnoses, they have some control over how they can manage it, and they learn to avoid all the anticipatory anxiety that sometimes sort of results from the symptoms. They do very well.
That's great.
And so, sometimes symptoms go away, sometimes they get better, and if they flare intermittently, they know, what to do and how to deal with them.
That's what's so important. That's why you do what you do to help these kids. So that's great. What's going on from a research perspective, and what do you see as the horizon?
Yeah, so there is a lot of research happening, all over the world, looking at different parts of the gut-brain axis and different pathophysiologic mechanisms on a microscopic, endocrine, immunologic level that may be off that are triggering symptoms. And there's actually a growing evidence of abnormalities that do happen. For example, in irritable bowel syndrome with diarrhea, do bile acids play a role? If there's more bile acids being excreted by the liver that can irritate the colon, like how much of that could be a trigger, and what if we absorb the bile acids, like could that reduce symptoms? We have shown that there is a subset of patients with IBS where that is, again, a trigger that we can treat to help reduce symptoms. And the other thing, for example, that we're actively working on is understanding the hormonal changes that, why girls are more often affected than boys, but also why after puberty more so than before. And some, exciting research about hormone receptors in the gut that may play a role. Our team here specifically, we have focused a lot on studying the outcomes of patients with disorders of gut-brain interaction, specifically in the context of the multidisciplinary clinic, and really shown that it works.
It sounds like, really all of this work right now is really focused on improving the treatment options for patients so that we can help our kids, enjoy their life every day. It's really great. Well, so now it's that time, my favorite part of the show, where we have an opportunity to ask you, as our expert, to prescribe what's called doctor's orders. And this is where you give a prescription to, our parents and others listening of things that they can do to help raise healthy, happy kids. So, Dr. Beinvogl, what are your doctor's orders today?
I would like to emphasize again that IBS is a real, true condition. It's very important to take patients seriously and then believe that they're having pain. Just because there's no test for it doesn't mean they don't have pain, right? And at the same time, the more we focus on it, the more it intensifies. So it's this double-edged sword. That's where also the role of parents and families is very important. Be the coach and cheerleader through all of this.
It's really important advice for all those parents, especially that are dealing with this, that they have an important role to play.
Very much so.
Thank you, as always, to our guest expert, Dr. Beinvogl, and to our guest parent, Amy. If you'd like to learn more about gastrointestinal issues in kids, please check our website for more information. Thank you so much, and see you next time.